When most people picture a heart attack, they picture the same scene. Sudden intense chest pain, clutching the arm, collapsing. That image comes from decades of medical research conducted primarily on men, where that pattern of symptoms is indeed common. It has also shaped public understanding of what a heart attack looks and feels like in ways that are actively dangerous for women, because women's heart attack symptoms frequently look nothing like that. Heart disease is the leading cause of death for women in the United States. More women die from it each year than from all cancers combined. And yet a significant proportion of women who experience early warning signs dismiss them, wait longer before seeking help, and consequently receive treatment later than men do in comparable situations. Understanding why this happens and what the actual warning signs look like is genuinely life-saving information. The most commonly overlooked early heart attack warning sign in women is extreme fatigue. Not the ordinary tiredness that follows a demanding day or a poor night of sleep. A different kind of exhaustion entirely, one that feels out of proportion to what you have been doing, comes on suddenly or unexpectedly, and makes routine physical tasks feel disproportionately difficult. Women who have experienced this as a pre-heart attack symptom describe specific features that distinguish it from ordinary fatigue. Walking across a room feels exhausting. Getting dressed requires more effort than it should. Climbing a flight of stairs, which was previously effortless, suddenly feels hard. Daily routines that normally require no conscious effort feel draining even after adequate rest. This type of fatigue can appear days, and in some cases weeks, before a cardiac event occurs. The reason so many women miss this signal is both cultural and biological. Women in midlife and beyond are culturally conditioned to push through discomfort, to attribute physical symptoms to stress or aging or hormonal changes, and to deprioritize their own symptoms in favor of responsibilities to others. When extreme fatigue appears, the default explanation is usually stress, menopause, poor sleep, or simply getting older. These explanations are frequently correct, but when the fatigue feels unusual, appears suddenly, or persists for several days, it deserves medical attention rather than rationalization. Women's heart attack symptoms differ from men's in ways that are well documented in cardiovascular research, but not well known in public health education. In addition to extreme fatigue, the symptoms women commonly report include shortness of breath during normal activities like walking or climbing stairs, upper back or jaw pain, or pressure that does not have an obvious musculoskeletal cause, nausea or stomach discomfort that resembles indigestion, and lightheadedness or dizziness that feels unusual. Chest discomfort may or may not be present, and when it is often described as pressure, tightness, or fullness, rather than the sharp stabbing pain people typically imagine. None of these symptoms are individually diagnostic. Each has many possible explanations. The important pattern to recognize is that these symptoms, particularly when they appear together or persist unusually, or when they feel different from anything you have experienced before, warrant prompt evaluation rather than delayed rationalization. The threshold for calling a doctor or going to an emergency room should be lower, not higher, because the consequences of delayed treatment are severe and the potential cost of being checked out unnecessarily is low. The midlife period specifically deserves attention in this context. Before menopause, estrogen provides significant cardiovascular protection. It helps maintain favorable cholesterol profiles, supports the flexibility and health of blood vessel walls, and has anti-inflammatory effects on the cardiovascular system. As estrogen levels decline during perimenopause and menopause, these protections diminish. LDL cholesterol tends to rise. Blood pressure often increases. Body fat distribution shifts toward the abdomen, which is metabolically more active and more inflammatory than fat stored elsewhere. The combination of these changes substantially increases cardiovascular risk in the years following menopause. This does not mean heart disease is inevitable after menopause. It means this period of life is an important window for taking cardiovascular health seriously and building habits that support it. Physical activity, particularly aerobic exercise and strength training, directly addresses several of the cardiovascular risk factors that menopause worsens. Walking consistently, with a target of roughly 150 minutes per week of moderate intensity activity, supports blood pressure regulation, circulation, and cardiovascular fitness. Strength training 2 to 3 times per week maintains the lean muscle mass that supports metabolic health and blood sugar regulation. Nutrition during this period matters substantially for cardiovascular risk. Diets built around lean proteins, vegetables, fruits, whole grains, and healthy fats from olive oil, avocado, and nuts support favorable cholesterol profiles and reduce inflammatory load. Adequate protein intake is especially relevant for women in midlife because it supports muscle maintenance at a time when muscle loss accelerates, and because protein stabilizes blood sugar in ways that reduce the metabolic risk factors associated with cardiovascular disease. Stress management is not peripheral to cardiovascular health. It is central to it. Chronic stress elevates cortisol, which raises blood pressure, promotes inflammation, disrupts sleep, and drives behaviors like eating less well and exercising less. The cardiovascular burden of unmanaged chronic stress is measurable and significant. Physical activity is one of the most effective stress management tools available. Sleep, social connection, and practices that activate the parasympathetic nervous system, including deep breathing and time in nature, also produce documented reductions in cardiovascular stress markers. The broader message from all of this is about recognition and action. Heart attacks in women do not always look like heart attacks. The warning signs are often subtle, often attributed to the wrong cause, and often dismissed for too long. Unusual fatigue that is sudden, disproportionate, or persistent, combined with any of the other symptoms described here, is a pattern that warrants prompt medical attention rather than a few days of waiting to see if it resolves. Your body communicates what it needs. The most important skill in managing long-term health is learning to recognize when those communications deserve immediate attention rather than rationalization. New videos every day covering the health information that actually matters for the decisions that protect your life. Subscribe and stay with us. There is one additional point about how the medical system itself has contributed to this problem that is worth naming. Because most early cardiovascular research was conducted on male subjects, the clinical diagnostic criteria and the symptom presentations that medical training emphasized were male pattern. When a woman presented to an emergency department with fatigue, nausea, and jaw pain, but no classic chest pain, the pathway to cardiac evaluation was historically less clear, and the threshold for initiating it was higher. Research on treatment disparities has consistently found that women wait longer to be seen, are less likely to receive cardiac catheterization, and receive thrombolytic therapy less frequently than men presenting with equivalent conditions. This is changing as cardiovascular medicine increasingly incorporates sex-specific research. But awareness at the patient level matters independently of what happens in emergency rooms. A woman who recognizes that her symptoms might be cardiac and communicates that explicitly to healthcare providers, rather than presenting vaguely with exhaustion and letting the provider determine the framing, is more likely to receive rapid, appropriate evaluation. Knowing the symptoms, taking them seriously, and advocating clearly for cardiac evaluation when the pattern fits is not overreacting. It is acting on information the research is unambiguous about. Women's heart attacks present differently. Women delay care longer, and that delay costs lives that earlier action would save. If something feels unusual, persistent, or different from your normal baseline, trust that instinct. Get checked. The cost of being wrong is low. The cost of waiting when you are right is